I'm Mala Reddy. I'm one of the medical oncologists here at Kaiser Permanente Oakland Medical Center, and I have the privilege of taking care of many of our melanoma patients here in the East Bay. You've heard from Dr. Kavakansky and Dr. Chong about some of the really exciting treatments that we have available for melanoma. But as you know, those treatments do have challenges associated with them. And so what I'll be talking about today is how do we best manage the side effects from those treatments. Can everyone hear me okay? Okay, great. So we'll speak first on immunotherapy. Immunotherapy is actually a relatively new treatment that's been born out of an old idea. In 1909, a man named Paul Ehrlich put forth a hypothesis called immune surveillance. And the idea was that the immune system is actually controlling our cancer cell development and growth. And over the years, as you can see, there's been many studies looking at T cells and their involvement in the immune system. And then ultimately that there are medications that have been used to actually remove the roadblocks or the obstacles that were preventing the immune system from being more effective in killing melanoma cells. Those roadblocks are called immune checkpoints, and there are a few that have been identified. One is called programmed cell death protein 1, or PD-1. There's PDL1, which is programmed cell death ligand 1, and then also CTLA4. This is a slide from the Nobel Prize presentation looking at how immunotherapy works on melanoma cells. You can see in the picture to the left that there are melanoma cells that are developing within the skin. And there is an APC, or what is called an antigen presenting cell, which is taking unique information, or essentially the code from those specific melanoma cells. It then carries that information into our lymph nodes where there are naive T cells that are present. Those are T cells that are, in essence, ready to fight, but they need information on their enemy first in order to find that enemy and effectively destroy it. As you can see, there's a process that those cells undergo called T cell priming. And that is where the APC shares that information with the T cell, and the T cell then becomes activated. You can see that CTLA4 can actually function as a roadblock in that process, and an anti-CTLA4 medication can actually activate that process. The T cell then migrates to the tumor tissue, or what we've been referring to as the tumor microenvironment. And in that phase, it's actively trying to destroy melanoma cells, but the PD-1 and PD-L1 can then act as a roadblock during that process. So our anti-PD-1 medications are trying to, in essence, take the reins off the immune system and allow for our T cells to destroy those melanoma cells. There are 3 immunotherapies that are approved for melanoma: ipilimumab, which is the anti-CTLA4 medication, nivolumab, and pembrolizumab, which are anti-PD-1 medications. As you can see, immune-related side effects can affect our bodies from head to toe. The most common areas to be affected are our skin, our gastrointestinal tract, and also our liver. But there are also other areas that can be affected, such as our eyes, our kidneys, our endocrine system, our lungs, and even our neurologic system. And if these side effects are not appropriately recognized or treated, they can become serious and, in rare cases, even life-threatening. So it is vitally important for us as oncologists to be asking our patients if they're experiencing these side effects, and for our patients to be counseled on what things to mention to us. You can see here there's a graph of when these side effects might occur. On the vertical axis is looking at severity or toxicity grade, and on the horizontal axis you'll see time in weeks. The initial side effects to occur are rash and diarrhea. Those usually can occur anywhere from 2 to 4 weeks of starting treatment. The other side effects that can occur later on are the effects on the endocrine system and liver. We'll start first with the skin. This is the most commonly affected organ from immunotherapy. And the most common effect on the skin is something called dermatitis, which is redness or itching of the skin. It occurs in about half of patients who are on ipilimumab. It's a little less common in patients who are on the PD-1 inhibitors. I've used a grading system here of mild, moderate, and severe. Your physicians may talk to you about a grading system of 1, 2, 3, and 4. I've combined grades 2 and 3 in the moderate category for ease, but it's always best to speak to your physician if you have questions on a side effect you might be experiencing and what grade that might be. For those patients who are experiencing mild dermatitis, we can continue their immunotherapy while we're treating that dermatitis. And oftentimes that involves using simple things such as moisturizers, topical steroid creams like over-the-counter hydrocortisone or prescription steroid creams, and also counseling our patients on avoiding sun exposure. For those patients with moderate dermatitis, we may consider holding their immunotherapy for a short period while their dermatitis resolves. And we also may consider using oral steroids such as prednisone. Those patients oftentimes will be evaluated by a dermatologist to see if there are any other measures that can be taken to treat their dermatitis. And for those patients with severe dermatitis, so these are patients who not only have redness or itching, but may actually have blistering or peeling of their skin, then we do indeed need to hold their immunotherapy. We may need to admit those patients to the hospital for intravenous steroids and also consider switching their treatment entirely. This picture here that you see is a gentleman who had a moderate dermatitis as a result of immunotherapy. So you can see there's a very red, angry-looking rash there. The next most common side effect with immunotherapy is its effect on our gastrointestinal tract. And that usually is in the form of something called colitis. And the symptom that patients experience with colitis is diarrhea. Immunotherapy can also cause more vague gastrointestinal side effects like nausea and abdominal pain, but colitis is generally the issue that we find the most common. About a third of patients on ipilimumab will experience some degree of colitis, and up to 10% of those patients will actually have severe colitis. It is less commonly seen with our PD-1 inhibitors. If a patient has mild colitis, and that means they have less than 4 more bowel movements over their baseline, so whatever is normal for that patient in terms of number of bowel movements, there is only a slight increase on top of that. For those patients, we can continue their treatment safely. We may need to monitor them a bit more closely for any signs of dehydration, and certainly ask for them to let us know if the bowel movements increase in frequency. For patients who have a moderate colitis, meaning that they're having more than 4 to 6 bowel movements over their baseline, for those patients, we will need to hold their immunotherapy until they recover. We may need to consider discontinuing the immunotherapy entirely if they are on ipilimumab. We will give them oral prednisone, which again is a steroid medication, and we'll ask them to see one of our gastroenterology colleagues to be evaluated, and this oftentimes means a colonoscopy to look at the walls of the colon and get a sense of how inflamed they might be. If the colitis is severe, again, we must permanently discontinue the immunotherapy. We would start intravenous steroids in the hospital, and we would use a medication called infliximab. Infliximab is an anti-tumor necrosis factor alpha medication. It is commonly used in other types of inflammatory colitis, and it is used now for patients who have immunotherapy-related colitis. As you can see in the pictures there, in the top left is a picture of a patient who is on ipilimumab and had a colonoscopy. The small white arrow, you may not be able to see this well, but is pointing at a punctate white ulcer. As a result from the immunotherapy, there are actual erosions of the tissue in the colon. The black arrow is pointing to areas of bleeding. And on the right side, you'll see what that looks like under the microscope. Those dark blue cells are actually all of our immune cells. And rather than just attacking the melanoma cells, they are unfortunately attacking the colon wall as well. Hepatitis is an issue that can occur with immunotherapy. It is one of those later side effects that I mentioned that you saw in that graph. It occurs in about 10% of patients who are on ipilimumab and is a bit more common with our PD-1 inhibitors, nivolumab and pembrolizumab. If the hepatitis is mild, meaning that there is a rise in the liver function test that we routinely do as part of these treatments, but a patient feels well and is not having any symptoms from that, we can continue their immunotherapy. We would most likely monitor their liver function tests more frequently so that we can catch any further rise in those tests. If they have a moderate issue, meaning that they have a more significant rise in their lab test, then we would need to hold their treatment. Also, if they're developing any symptoms of hepatitis, and the symptoms oftentimes can be a bit vague, but they can be things like fatigue, nausea, or what's called jaundice, which is yellowing of the skin or eyes. In that case, we would definitely need to hold treatment until those issues resolve. If someone unfortunately develops liver failure, which is quite rare but can happen, then we would need to permanently discontinue their treatment and start them on intravenous steroids in the hospital. Infliximab, the medication that I mentioned earlier, which can be used for some of these immune-related side effects, is not typically used for liver failure or hepatitis because infliximab itself has a rare risk of liver failure. You can see in that picture there, that's a picture of what the liver looks like under the microscope when there's hepatitis. And that pink are the healthy, good liver cells, and the dark blue cells are all of our immune cells, again, causing problems in the liver. The endocrine system can be affected by immunotherapy. It is a more rare side effect. It occurs in about 4% of patients on ipilimumab and less than 10% of patients on nivolumab or pembrolizumab. If it is mild, meaning that there are abnormal lab tests, and we routinely check for thyroid function for patients who are on these treatments, then we oftentimes will observe and continue monitoring those lab tests. If there's a more significant change in the lab tests, or if somebody is developing symptoms either of thyroid dysfunction, pituitary dysfunction, or adrenal dysfunction, and those can be fatigue, change in blood pressure, change in electrolytes. In that case, we would need to hold treatment. We oftentimes will have our patients evaluated by an endocrinologist who can then suggest if there's appropriate hormone supplementation that's needed. And we may need to consider discontinuing the treatment altogether, depending on the severity of this issue. For those patients who do indeed have severe endocrine issues, we hold treatment until all of those issues have returned to their baseline with the appropriate hormone supplementation. And again, we would need to consider whether immunotherapy is the right treatment for them. In terms of the effect on our respiratory system, the most serious effect is a condition called pneumonitis, which is in essence inflammation in the lung tissue. This is typically diagnosed by chest X-ray or CT scan or pulse oximetry, and most often putting these tests together. In terms of symptoms, patients may experience shortness of breath or cough as their symptom. It is thankfully a rare side effect. It occurs in about 5% of patients on ipilimumab and 3% of patients on the PD-1 inhibitors. If it is mild, and generally this means that a patient has had a scan done for another reason, and we find that there is pneumonitis present in one lobe of their lung on that scan, but they have no symptoms, then we can hold their immunotherapy, but consider resuming it if there are no further symptoms. And we do need to monitor them very closely by CT scan and pulmonary function testing. If someone has moderate pneumonitis, meaning that there are symptoms present or there is more than one lobe of their lung affected, then we need to hold or permanently discontinue their immunotherapy. We need to initiate oral steroids, and we'll oftentimes have them meet with one of our pulmonologists. And in that case, they may undergo a bronchoscopy for further evaluation. If the pneumonitis is severe, meaning again that a patient has symptoms or there's a good amount of their lung that is unfortunately involved with the pneumonitis, we must permanently discontinue their immunotherapy. We would admit them to the hospital for intravenous steroids and intravenous antibiotics. They would undergo a bronchoscopy, and we can consider the medication that I mentioned earlier called infliximab. As you can see here, there's a CT scan of a patient who is receiving immunotherapy and developed pneumonitis. The lungs, or the organs that we're looking at on both sides, normally should be essentially dark black because that's generally the color of air on a CT scan. But you can see there's a lot of white stranded material in the lungs, particularly in the CT scan on the top. On the bottom, you can see the patient has been undergoing treatment for pneumonitis, and overall the scan looks improved. Some less common side effects with immunotherapy are organ systems that can be affected but are quite rarely affected. There can be what's called acute kidney injury, which means an abnormal creatinine level, which is a lab test that is routinely performed during immunotherapy. The heart can be affected by immunotherapy, again, quite rare, but it can cause inflammation of the heart muscle called myocarditis, the coating around the heart called pericarditis, or arrhythmia, which is an abnormal heart rhythm. The eye can be affected by immunotherapy. There can be inflammation of different parts of the eye, the conjunctiva, the uvea, and some patients complain of dry eyes during this treatment. And then finally, the neurologic system can be affected. There's a condition called Guillain-Barré, another condition called myasthenia gravis, where the nerves can actually be inflamed and affected by the immunotherapy. Moving on to targeted therapy. This is a graphic of something called the RAS-RAF pathway, or also known as the MAP kinase pathway. You can see on the left is what the normal steps are for that pathway. You can see an enzyme called BRAF and another enzyme called MEK. And that cascade of events results in what's called cell proliferation or cell growth. If you look next to it, there is another pathway in which the BRAF gene has a mutation present called V600. And in that case, what happens is that there is a clonal expansion or further cell proliferation and cell growth that occurs as a result of that mutation. And then to the right, you can see that there are medications now available to interrupt this process. The BRAF has medications to actually inhibit that enzyme called BRAF inhibitors, and there are also inhibitors of MEK. This is a list of the currently available BRAF and MEK inhibitors for melanoma. BRAF inhibitors have a variety of side effects, which thankfully overall are less serious than those of immunotherapy, but can still pose challenges for our patients in terms of their quality of life. The skin is a common area to be affected. There can be an increase in the development of squamous cell skin cancers in patients on BRAF inhibitors. It's therefore recommended that our patients on these medications see a dermatologist routinely during their treatment so that they can have skin checks done for that purpose. Patients do have a lot of generalized side effects such as fatigue, fever, joint pain. The eyes can again be affected with targeted therapies. In terms of cardiac side effects, there's a particular arrhythmia called prolonged QT syndrome, which requires close monitoring of EKGs and electrolytes during this treatment. There can be diarrhea as a result of BRAF inhibitors. And another rare side effect from BRAF inhibitors is something called a peripheral facial nerve palsy. With MEK inhibitors, again, the skin is commonly affected. Patients can have a rash, hair loss, or a condition called hand-foot syndrome, which is where the patient's hands on the soles and, on their palms and then also on their feet, on the soles of their feet, can actually get red, dry, and sometimes even peel. MEK inhibitors can also cause diarrhea. They also cause generalized side effects such as fevers and chills. They can rarely cause a cardiac side effect of what's called a decreased ejection fraction, which means weakening of the heart muscle. And they also can cause visual changes. There is a rare side effect that is particular to MEK inhibitors called MEK-associated retinopathy. So we'll start first with how to manage skin side effects on these medications. For the photosensitivity or sensitivity to sun exposure, it's very important to use sunscreen. That's important for any of our melanoma patients anyway, but it is particularly important to try and prevent this issue. For dry skin, obviously moisturizers can be used to treat that. There are some patients who get a folliculitis, which is inflammation of the hair follicles. That often can be treated with topical steroids or antibiotics. There can be a painful nodular rash called Erythema nodosum. That can be treated with topical or oral steroids. And then, of course, the lesions that I mentioned earlier, squamous cell cancers or keratoacanthomas, those need to be referred to dermatologists for excision or removal. For diarrhea, if it is mild, meaning that patients may complain of a few loose stools, but nothing really significantly over their baseline, we can continue treatment. We may offer recommendations on dietary changes or use of loperamide, which is an over-the-counter anti-diarrheal. For patients with moderate diarrhea, meaning that they're having more than 4 to 6 bowel movements over their baseline, then we do temporarily hold treatment. Once the diarrhea has resolved and patients are having their normal baseline of bowel movements per day, we can resume treatment and would often do so at a lower dose. If someone is having severe diarrhea, meaning that they're having more than 7 bowel movements per day over their baseline, we do need to hold their targeted therapy. We may even consider permanently discontinuing their treatment. Oftentimes, those patients may need to be admitted to the hospital for intravenous fluid hydration, and we might consider having them see one of our gastroenterologists for a colonoscopy. Fever is a particularly challenging issue with targeted therapies. It's quite common and is something that can interfere with quality of life in terms of how one feels. If the fever is mild, meaning that it is between 100.4 to 102.2 degrees Fahrenheit, then if patients are well, we can actually continue their treatment. And what we do at that point is ask for them to take Tylenol as needed. They can even add NSAIDs such as ibuprofen. If they have a moderate fever, meaning a fever that is greater than 102.3 and up to 104, then we may need to consider admission for them, and we need to be looking for perhaps other causes such as infection. If someone has severe fever, meaning fever over 104, and that fever is sustained for over a day, those patients do need to be admitted to the hospital, and we oftentimes will need to permanently discontinue their treatment. We also can consider low-dose steroids because that can sometimes help for that high fever. To review, in terms of BRAF and MEK inhibitors, these are medications that are oftentimes given together. And so we talked about some of those side effects in isolation, but I just wanted to mention that when they are given together, interestingly, there is less skin toxicity that occurs, but diarrhea tends to be more common, and fever and chills as well. There is some anecdotal evidence in the form of what are called case series showing that even though there are many patients who need to have interruptions in their treatment, that at least in those series, their outcomes were the same. And that there is also some data to be aware of that for patients who are over the age of 75, some of these side effects that we just discussed tend to be in the moderate and severe category in those patients. And thank you all for coming today. We greatly appreciate all of you who are here locally with us as well as streaming from home. Thank you.